So this is joint work with a large team of co-authors, and importantly, is a collaboration between psychiatrists and economists. And to motivate this work, I want to start with this fact that depression is actually now the world's leading cause of years lived with disability, according to the WHO. It's very common. It's often a recurrent condition that people deal with on and off throughout their lives, and especially in developing countries, there's an enormous treatment gap for depression. So in India, at least 85% of people with depression get no care or help for it whatsoever through the healthcare system. And my guess is the actual number is even higher, and this is going to be similar in many developing countries. It's also true in rich countries that a lot of people with depression don't get help. In developing countries, I think the reason why you have so little treatment is very simple. There's hardly any psychiatrists, there are hardly any trained psychologists who can provide sort of evidence-based modern forms of psychotherapy or pharmacological treatment for that matter. And researchers and practitioners in the field of global mental health have put in enormous efforts in recent years to develop simple forms of psychotherapy, which can be delivered to patients by non-specialists with really minimal training, a few weeks of training and on-the-job training. And there's a substantial evidence base now showing that these interventions can be quite effective at treating depression, at reducing symptoms of depression in the short run. And by the short run here, I mean effects, say 6 weeks, 3 months, 6 months, and in some studies all the way up to 12 months after treatment commences. Okay. What this paper is going to try to do is tell us something about the long-run treatment effects of such therapies on mental health. It's going to do this by collaborating with psychiatrists who have previously conducted clinical trials to treat depression in Goa in India. And we're going to go back and follow up on the participants from these trials 4 to 5 years after enrollment. So we're going to see what's the long-lasting effect, if any, on mental health. We're also going to try to shed light on demand-side barriers for therapy, because one stylized fact in the literature and talking to practitioners is that even though therapy seems to be very effective, there's often low demand for it. People often don't take up therapy even when it's available, more so in rich countries. And so we're going to try to ask, do people correctly understand the efficacy of therapy? And what's the effect of actually experiencing therapy on your beliefs about it? And then we're going to spend a lot of time talking about the effects of therapy on your self-confidence, your beliefs about yourself, and how you react to feedback. Why do we pick this outcome? It's because, at least in some theories of depression, pessimism about yourself and about the world and so on is considered to be something that's at the heart of depression. Okay, so we're trying to understand, does therapy change the way you see yourself and the way you react to feedback about yourself? I'm not going to talk in the interest of time today about other outcomes in the paper, which include things like economic preferences, things like your patience, your altruism, your risk preferences, as well as sort of the downstream welfare outcomes many economists would care a lot about, such as your employment, your income, your consumption. Okay? But you can find this in the paper. So what did we do exactly? We followed up on 2 RCTs that were done in India, where participants were initially screened for depression using a very commonly used tool in this research, which is the PHQ-9. This is asking people 9 questions about the frequency with which they experienced certain classic sort of central symptoms of depression, such as feeling down, depressed, or hopeless, but also physical things like changes in appetite, difficulty sleeping in the last 2 weeks. This is a highly well-validated screening tool, which has been validated in the local context, in the local language, in previously published research. It was also used in the original trials. The treatment groups in these 2 trials received, as I said, these very simple, inexpensive forms of therapy, which cost about $70 to deliver per patient, and that includes all the costs of training the people who are delivering it, supervising them, transport costs, incentives, all of that. Okay, so this is a really inexpensive intervention. And what was the therapy doing? This is not kind of Freudian psychoanalysis, right? This is a very simple stripped down form of therapy which would officially sort of count as cognitive behavioral therapy, but in fact mostly emphasizes the behavioral part of this, what's called behavioral activation. This is teaching people the relationship between the activities they engage in and the resulting mood, helping them structure and schedule pleasurable activities, and then to some extent also engaging in problem solving in terms of problems they're facing in their lives. So essentially, you're taught to take actions that will improve your mood. And if you do this for a while, may be effective in reducing depression. You're kind of taught these tools and strategies to deal with and potentially to prevent future episodes of depression. The control group, I won't get into the details, but they're provided sort of their screening result. Their healthcare provider has provided the screening result and some guidance on how to help people. But in practice, what this means, given the local context and the scarcity of providers and the extreme burden on the healthcare system, is that the control group really doesn't get a lot of additional treatment. Okay? I'm going to focus on the first of the two trials. This was the larger of the two trials, and in fact was the trial that had effects in the short run. The second trial, for which you'll also find all the results in the paper, had not had its results unblinded when we started to follow up on, to try and get the longer run effects. And then it was discovered that it had very small, very modest short run effects on depression. Okay, so as you might expect, if you really didn't have an effect in the short run, you're not going to have an effect in the long run, at least on mental health. All right. A little bit more about this, the sample, this HAP sample, the main trial. This is adults between 18 and 65 years of age, including men and women, screened for a pretty high level of depression at baseline. This is what's called moderately severe depression, a PHQ-9 score of above 15. The treatment is really quite, is much shorter than a normal course of psychotherapy. It's only 6 to 8 sessions, each of which is about 40 minutes, delivered over 2 to 3 months, and then treatment stops. Okay. Approximately 70% of the treatment group who was offered treatment actually completed treatment. Okay, that is, went through the assigned 6 sessions, or perhaps the therapist judged before that they don't need more sessions. So what were our follow-up rates? About 5 years after this trial commenced, we were able to find about 75% of people. Follow-up rates were balanced across treatment and control groups, and the covariates of the people we found were also balanced across the treatment and control groups. So we don't seem to have differential attrition issues. The sample is primarily female. This is partly driven by the fact that women are about twice as likely as men to suffer from depression. And then, there's some perhaps additional selection in the original trials. On average, the participants have 6 to 7 years of formal education. Consistent with low female labor force participation in rural India, about a third were employed at baseline. So the first and perhaps the most important result we have is that the substantial short-run effects of this trial, which had already been established previously, so the outcome here is the fraction of people who are at least moderately depressed. And what you can see is, there were substantial effects 12 months out. This was in the previously published research. And somewhat surprisingly, and I should say not predicted by experts from whom we elicited forecasts, those effects largely persist for 5 years. So this is really going to take the sort of, in a way, the cost effectiveness analysis for this intervention, which was already quite favorable, and really make it remarkably more effective. And give you a sense of kind of where this study sits relative to the literature. What we're plotting here are estimates from the existing literature studying these low-cost, simple forms of therapy in low and middle-income countries. And what you can see is, almost all the studies look at effects within a year or so. There's one, notable exception, a paper by Baranov and co-authors in the AER in 2020, which found 7-year-long effects. And then this is our kind of main trial, the HAP study, 5 years in. Okay. As I said, most experts in economics and also experts in mental health, including people who had designed these interventions and were involved in the original studies, underestimated the effect size we found 5 years out. Okay. So we think people should be updating their priors a bit based on these results. Why does this effect persist? Right. So this is not like, removing cancerous cells from your body where you think, well, of course, the effects, might persist. It's not totally obvious this would happen because depression is episodic. It tends to, you tend to go into remission and then you're at high risk of going back into a future episode of depression. Just to be clear, the treatment group really does not continue to use therapy. You might think I've experienced treatment, it helped me, I later go look for it when I need it again. In fact, we didn't find any evidence of that. Basically, there's very low availability. You might have thought the effects would come from improved economic circumstances, which might feed back into better mental health. In fact, that's kind of a virtuous cycle that we've written about and talked about in other work we've done. But in fact, we found no improvements in consumption or employment, perhaps related to the fact that there are other constraints on women's labor force participation in this context. So that's really not the mechanism. One possibility which we're now trying to collect more data to kind of nail down is that participants kind of learn these principles or tools of behavioral activation and were able to employ them to deal with future stresses. Okay. Then, as I said, we measured people's quantitative beliefs with incentives for accurate, belief elicitation to try to understand whether people thought therapy was effective or not, and whether experiencing treatment changed their beliefs. Okay. Now we're doing this years later, so it's a little bit tricky. We're asking people for the treatment and control group, what share do you think were depressed? Now 5 years after treatment, as well as at previous time frames. Okay, and what we find is in the red triangle are the quote unquote true estimated treatment effects of this trial, right? Which are quite large, and as I said, remain positive even 5 years out. In light blue are what the control group's beliefs were about these treatment effects, and dark blue are the treatment group's beliefs. So what you're going to see is that the control group tends to underestimate how efficacious treatment would be. These are people who didn't experience treatment, but we describe what the therapy would be like, and they don't really think it'll help that much. The treatment group, experiencing treatment tends to increase your beliefs about its efficacy. Right? So you might think that what this means is that baseline effective treatments will be underestimated. Of course, in a context where therapy is a very new idea, right? So it's not that you've heard about it from hundreds of people before. All right. Finally, how does therapy affect your beliefs about yourself? Right? So we were motivated particularly by this very influential hypothesis in psychology of what's called sometimes the sadder but wiser hypothesis, also sometimes known as depressive realism. This is the idea that you might have heard that to be psychologically healthy requires a certain amount of over-optimism, perhaps overconfidence, and that depressed people, in fact, are more realistic. They're lacking this kind of quote-unquote bias, but you might think, right, there's some adaptive role for this overconfidence. Now, even though it's a very influential idea, it's contested, and the evidence for it actually is not overwhelming, and of course is basically all cross-sectional correlational evidence. What we're trying to do is to say, well, what is the causal effect of therapy, which reduced depression, on these kinds of beliefs? And we're going to use an experimental paradigm from Mobius et al., where the idea is people will do some work, and in their case they did IQ tests and so on. We're doing more an economic work task, which is making bracelets, which later people can apply for jobs or sort of work from home with this kind of work. And we're going to elicit your beliefs about how good or fast you are at doing this work compared to others. Then we're going to give you some feedback about how good you actually were. The feedback isn't going to be complete and perfect and just tell you here's the bottom line. It's going to be noisy. So there's some room for you to kind of really pay attention to it, or perhaps to explain it away to yourself. Okay, like a lot of feedback in real life is, it's somewhat subjective. So what do we find? First, somewhat contrary to our priors and some expert predictions, the control group, which still has high rates of depression, is actually on average overconfident. They're overconfident by 13 percentage points about their own performance compared to others at baseline. And when they get more feedback, they actually become even more overconfident. So even though the sample has a lot of depression, there's a slight correlation of depression with this stuff in the cross-section, not much. But this sample actually looks just like college students in the US when they're getting feedback about their looks or about their IQ. That is, when I get negative feedback, I kind of ignore it. When I get positive feedback, I react to it. Okay, so I get even more overconfident, even though most of the feedback is saying, hey, you're not quite as good at this task as you thought. But the treatment group goes in the opposite direction. So contrary to at least my personal priors and also the priors of, I think, almost 100% of the experts whom we asked to make forecasts, going through therapy is not making you more overconfident and optimistic about yourself. It's actually making you more realistic about yourself, at least in this one very specific domain. It's making it perhaps okay to be honest about the fact that you're not the world's best at making bracelets. All right, I'm going to skip some of these in the interest of time. I know I'm running out. But I'll note one thing, that we found something quite similar also in the other trial in terms of the effects on self-confidence and belief updating, even though we didn't actually find long-lasting effects on mental health there, which suggests that therapy might have these independent effects. It might change your mental health, but it might have independent effects on your self-confidence and the way you react to feedback. In fact, we found that also for our economic preferences, which I'll leave for the paper. So just to wrap up, we've shown that a brief course of psychotherapy for depression can improve mental health for 5 years. It was a really inexpensive intervention. We calculate that it averted 9 months of depression over 5 years for the treatment group, per person. So for $7 kind of per month averted. So really a very effective intervention. It had lasting effects on people's beliefs about themselves. So in fact, therapy made people have more realistic views about themselves. So it made them happier, but also made them wiser in some sense. Okay. And one interpretation perhaps is that what therapy helps you do is to perhaps feel less threatened or feel less less distress from thinking of yourself as being, doing poorly at a given task. Right? So it perhaps reduces the need for sort of a self-protective overconfidence. We also showed that experiencing therapy makes people more positive about its efficacy. I didn't show you this, but we found some increases in self-evaluated patience and altruism, but no effects on employment or consumption. Thanks so much for your attention.
Thanks, Gautam. That was really interesting, and I really like how you approached it. I think I had just a question of how how to interpret this happier but wiser thing. So I guess like the updating results kind of support this idea of like you're happier because of therapy, but you're wiser because of the way you're updating. But if they're wiser, how do you reconcile that with the fact that in the beginning their baseline beliefs don't seem to be different, right? Like it's like you're just as overconfident as the people who never got psychotherapy at baseline. And how do you reconcile this with what I thought was cross-sectional evidence that it is still true that people who are depressed tend to have more realistic beliefs than people who are not depressed in the cross-section? So I was just wondering how you think about those two things.
Great question. So on the first one, I think one way to think about this is this was your overconfidence when when you're doing a very new task, right? And it's probably kind of hard to have a sense of where you are. In real life or many other things, you will receive feedback over time from the world, right? And so when we as experimenters go in or as do a survey and measure overconfidence, that's usually for something where you've had many chances to receive feedback in life, whereas here for this very tightly controlled experiment, you haven't ever received feedback on how good you are presumably at making bracelets. Now, you receive feedback about other things and maybe your physical ability in other ways. So that's that's kind of why I think in some ways I would put a little bit more weight on your final overconfidence after you receive feedback, but maybe that's one way to think about that. In terms of the cross-sectional correlation, in fact, your colleague here, Don Moore, has a new paper, showing that it just ain't so. In fact, I think that this may be a very fragile, this view that depressed people are more realistic, while I think a very popular view just does not have that much evidence, and with larger pre-registered studies, it may not be the case. Excuse me. I tested negative yesterday, I promise. But in our study, we did find, if you look at the cross-sectional correlation, there is a weak, non-significant relationship going in the direction of this depressive realism idea, that is of depressed people being less overconfident. It's not a strong relationship. And then therapy pushes in the opposite direction. As I said, that's further evidence that therapy is having these effects not through reduced depression. So, we started this paper very much thinking of therapy as just a lever to shift depression, but unfortunately it's more complicated than that. Therapy seems to have this effect independently of its effects on mental health.
I just wanted to know what kind of consumption, like data did you record? Was it just necessities or like substances also?
So, we didn't do the kind of like, when a developer economist really wants to measure consumption with a 2 hour long survey, we didn't do that. But, there's food, there's durable goods, there's some of these quote unquote temptation items. One thing we measured, we also measured is health expenditure. So there's this finding in the literature that poor mental health tends to correlate with high expenditures on physical health care as well. So, we had some of these categories and, we don't really find effects on any of them.
Okay, thank you.
I have a question regarding depression in men and women, since it's so different. Did you draw some conclusions from what you saw? Were there any differences between men and women during the study?
I think we're just underpowered to do that because in our pooled sample, 88% of the sample is women. So this is really mostly a study about women. So, we just don't have enough power to look at men.
Thank you for your presentation. I had a question regarding the individuals who are administering the psychotherapy. Did you have any criteria on selecting them, or was it self-selection? Also, were they representative of the same background or demographic as the individuals that they were providing therapy to?
Yeah, so they were from the same communities. That doesn't mean you'd be from the same village or the like. Actually, in one of the trials, even that was more true. But in the main trial, they're recruited from the local area. They're recruited through advertisements. They get a few weeks of training. So of course, there's selection into who does it, and there's evaluation. So people who seem to be good at it in training are the ones who are used in the intervention. And usually, I think there's kind of a gender match, but not always between the person delivering the therapy and the patient.
We're going to have 30 minutes after for general questions, so save them until then, but we're going to keep moving on to the next presenter. Thanks.